السلام عليكم ورحمة الله وبركاته. محاضرة اليوم بعنوان Fetal Malpresentation Part 1 Breech Presentation. The term malpresentation encompasses any fetal presentation other than vertex, including breech, face, brow, shoulder, and compound presentations. Breech presentation is the presence of fetal buttock and/or feet in the lower uterine segment. There are three types of breech. The commonest is extended or frank breech. The less common is flexed complete breech. And the least common is foot-length breech, in which a foot presents at the cervix. Here, as we see, this is the foot length, extended, flexed. Here the foot lick. What are the predisposing factors for breech presentation? Maternal, fibroids, congenital uterine abnormalities, as bicornuate uterus, uterine surgery, fetal or placental, multiple gestation, prematurity, placenta previa, abnormality, for example, anencephaly or hydrocephalus, fetal neuromuscular condition, oligohydramnios, polyhydramnios. If a breech presentation is clinically suspected at or after 36 weeks, this should be confirmed by ultrasound scan. What we look for in the ultrasound scan? First, fetal biometry. Second, amniotic fluid volume. Third, placenta site. Fourth, position of the fetal legs. And fifth, the scan should also look for any anomalies previously undetected. The three management options available at this point should be discussed with the woman, and these are external cephalic version, vaginal breech delivery, elective cesarean section. Planned vaginal delivery of a breech presentation is associated with a 3% increased risk of death or serious morbidity to the baby. External cephalic version. The procedure can be mildly uncomfortable for the mother and should last no more than 10 minutes. A fetal heart rate trace must be performed before and after the procedure, and it is important to administer anti-D if the woman is rhesus negative. What are the contraindications to external cephalic version? Fetal abnormality as hydrocephalus, placenta previa, oligohydramnios or polyhydramnios, history of antepartum hemorrhage, previous cesarean or myomectomy scar on the uterus, multiple gestation, preeclampsia or hypertension, plan to deliver by cesarean section. are the risks of external cephalic version or the complication: placental abruption, premature rupture of the membranes, cord accident, transplacental hemorrhage. You must remember the anti-D administration to rhesus negative women, fetal bradycardia. External cephalic version is a relatively safe technique and has been shown to reduce the number of cesarean sections due to breech presentations. The procedure is performed at or after 37 completed weeks of gestation near delivery facilities. External cephalic version should be performed with a tocolytic such as nifedipine. The woman is laid flat with a left lateral tilt, having ensured that has empty her bladder and is comfortable, with ultrasound guidance. The breech is elevated from the pelvis, and one hand is used to manipulate this upward in the direction of a forward roll, while the other hand applies gentle pressure to flex the fetal head and bring it down to the maternal pelvis. As we see here, this hand elevates the breech up, and the other hand helps to flex the head. We need to be that the head continue flexed all over the maneuver, as we see here. If external cephalic version fails, or if it is contraindicated, cesarean section is not indicated for other reasons, then the woman should be counseled regarding elective cesarean section and planned vaginal delivery. Prerequisite for vaginal breech delivery: feto-maternal. The presentation should be either extended or flexed, but feet not below the fetal buttock. There should be no evidence of fetal-pelvic disproportion, with a pelvis clinically thought to be adequate and to be estimated fetal weight less than 500 grams. There should be no evidence of hyperextension of the fetal head and fetal abnormalities that would preclude safe vaginal delivery, such as severe hydrocephalus, should be excluded. Management of labor. Fetal well-being and progress of labor should be carefully monitored. An epidural analgesia is not essential, but it may be advantageous. It can prevent pushing before full dilatation. Fetal blood sampling from the buttock provide an accurate assessment of the acid-base status when the fetal heart rate trace is suspected. There should be an operator experienced in delivering breech babies available in the hospital. Vaginal breech delivery should be characterized by masterly inactivity, which we call hands-off delivery of the buttocks. Full dilatation and descent of the breech will have occurred when the buttock become visible and begin to distend the perineum. Preparation for the delivery are made. The buttocks will lie in the anterior-posterior diameter. Once the anterior buttock is delivered and the anus is seen over the forehead, and no sooner than this, an episiotomy can be cut. Delivery of the legs and lower body. If the legs are flexed, they will deliver spontaneously. If extended like this, we may need using a pinard maneuver. This entails using a finger to flex the leg and knee, and then extend the hip, first anteriorly, then posteriorly, with the contraction and maternal effort. Then the lower body will be delivered. Usually a loop of cord is drawn down to ensure that it is not too short. Delivery of the shoulders. The baby will be lying with the shoulders in the transverse diameter of the pelvic mid-cavity. As the anterior shoulder rotates, the spine or the scapula will become visible. At this point, a finger gently placed above the shoulder will help to deliver the arm. As the posterior shoulder reaches the pelvic floor, it too will rotate anteriorly in the opposite direction. Once the spine becomes visible, delivery of the second arm will follow. This can be imagined as a rocking boat, with one side moving upward and then the other. Wasit maneuver essentially copies these natural movements anterior-posterior. Here, as we see the technique, delivery of the head. The head is delivered using the number 1 Mauritius Melvit maneuver. The baby lies on the obstetrician arm with downward traction being leveled on the head via a finger in the mouth and one on each maxilla. Delivery occurs with first downward and then upward movement. Number 2. Forceps applied to deliver the aftercoming head. An assistant holds the baby's body upward while the forceps are applied in the usual manner. As we see here, finger in the mouth, other in the maxilla. Here suprapubic pressure, gentle pressure. The other hand helps to flex the head. Here the forceps for the aftercoming head, placed over the head. Assistant hand to hold the baby's body. Gentle suprapubic pressure. What are the complications of breech labor and delivery? Increased risk of cord prolapse, particularly with foot-link breech. Increased risk of CTG abnormalities as cord compression is common. Mechanical difficulties with the delivery of the shoulders and or aftercoming head, leading to damage of the visceral organs or the brachial plexus. Delay in the delivery of the head may occur with a larger fetus, leading to prolonged compression of the umbilical cord and asphyxia. Uncontrolled rapid delivery of the head may occur with a smaller fetus and predispose to tentorial tears and intracranial bleeding. A small preterm fetus may deliver through an incompletely dilated cervix, resulting in an head entrapment. A woman with an unstable lie at term should be admitted to the antenatal ward. The normal plan would be to deliver by cesarean section if the presentation is not cephalic in early labor or if a spontaneous rupture of the membranes occurs. In multiparous women, an unstable lie will often correct itself in early labor as long as the membranes are intact. Thank you for listening.